Hi, I'm Dr. Duretti Fufa, a hand and reconstructive surgeon here at the Hospital for Special Surgery. For patients with a palpable cord, I like to present 3 treatment options for Dupuytrens contracture, including needle aponeurotomy, which we'll be discussing today, Xiaflex injection, or operative excision. My preference is to begin with needle aponeurotomy as it is the least invasive. We schedule the patient for a 45-minute office-based procedure visit. This patient has already had needle aponeurotomy on his left hand, and today we'll be working on his right hand. First, I begin by documenting the pre-procedure deformity using photographs as well as goniometer measurements. I also perform a detailed 2-point discrimination on both the radial and ulnar aspect of each digit that's going to be manipulated. I palpate the cord and mark sites that will be suitable for needling. And then prep the skin for a semi-sterile procedure. When numbing the patient's skin, it's important to only infiltrate very superficially and not affect the deeper digital nerves so that the patient does not lose sensation in the digit. Their feeling is important to protect the digital nerves from injury, which they will inform you of if they feel electrical sensations, indicating that you should not proceed in that direction. The needle procedure is performed using an 18-gauge needle, palpating the cord and feeling through the tip of the needle the transection. After needling, gentle manipulation can be performed. And then the procedure begins. My preference is to go from a proximal to distal direction, and continual examination both of the patient's distal fingertip sensation as well as their ability to move the finger is important to ensure that you have not injured either the digital nerves or the tendons. Again, making sure just to infiltrate superficially. The transection of the cord can be felt through the needle as well as oftentimes heard. Here's the patient's pre- and post-procedure correction. At the conclusion of the procedure, I ask the patient to make a fist around gauze pads for several minutes for hemostasis and then apply Band-Aids. At that point, we repeat the photographs as well as goniometer measurements and 2-point discrimination exam. As long as the 2-point discrimination is reliable below 10 millimeters, I am confident that there's been no injury to the digital nerves. The patient then goes to therapy to have a splint created, helping to maintain the extension gained. Whether the splint is hand-based or finger-based depends on whether the primary procedure was performed for metacarpophalangeal joint or interphalangeal joint contractures. How did you choose the needle procedure out of the 3 options that we discussed?
You recommended it as the least invasive and the quickest recovery and the least swelling and so on, and I thought the difference might be a year or so in the possible need to return, but for that, if that was the downside, it was worth doing less. I expected to feel some pain, and I felt no pain at all. I did, however, feel the sensation of you working on it, and of course I could hear the little crackling, and it was a new experience to feel a sensation, feel the procedure, but not to feel pain. And I thought, either you feel nothing or something's painful. It's like the dentist. Either you've got Novocaine or you don't. But this was an interesting thing. I could feel I never lost sensation, but there was never any discomfort.
These are the instructions we give the patients post-procedure. They are allowed to remove the Band-Aids later in the day and get the hand wet ad lib. I suggest that they use ice or take anti-inflammatories by mouth if they're experiencing pain or discomfort, but this is an infrequent complaint. The splint should be maintained full-time for the first 48 hours and then nightly for the remainder of a month, and we next visit at 1 month following the procedure to repeat the measurements. If there's been any concern about altered 2-point discrimination, I ask the patient to return at 1 week for repeat 2-point discrimination examination.